is the topic. The topic is not that okay, patient has come from outside and figure out fear extra unknown origin. ऐसा नहीं होता ये. Fever and ICU. So it's a very important topic for you because more often than not, the fever in ICU will be one of the most difficult things to manage inside the intensive care unit because patient comes for something, gets something else. So not only is the logistical problems, it's also with respect to getting to the diagnosis as to why this is happening. Okay, and like for example, you have fever, what do I do? You have fever, what do I do? That's very important to know when, why, what to do. When, why, what to do. You can't just do anything. Okay, it's not like if you're in ICU, it doesn't work like that. Okay, so fever in ICU has to be methodically, very methodically you have to go approach. The approach has to be very methodical in fever in the ICU. It's a very important exam question, and also it's a question that can come in any paper. For example, if you have just this about say traumatic brain injury, you have a case of traumatic. See, there are some stock cases. TBI stock case hota hai. So toxic shock syndrome is a stock case. Then we have pancreatitis as a stock case. Shock, ekdam proper stock case. These are all stock cases. इसमें ना third or fourth question after you finish all this is patient develops fever in ICU. Most of these have got this. That patient has now developed a fever in ICU. How will you proceed? So usually, though it may not come as a main case, but 99% will come in your exam as a prelude to the further. In the case, you will go ahead and say, now develop patient has a fever. Now what to do? You understand? Huh? So let's go to that now. Okay.
Good morning, everyone. So fever in ICU. Before that, let's know something about fever terminology. So fever is coordinated neuroendocrine autonomic and behavioral response that is adaptive and essential part of acute phase response to immune stimulus or tissue injury. It is coordinated by hypothalamus, neural input from peripheral thermoreceptors and humoral cues from inflammation or infection. The normal body temperature is around 37 centigrade or 98.6 Fahrenheit measured in the axilla. Core body temperature can be around 0.5 centigrade higher than the oral temperature and 0.2 to 0.3 centigrade lower than the rectal temperature. Diurnal variation of temperature occurs with evening rise up to 100 Fahrenheit also.
So when you say normal temperature, you don't say as 37 degrees, okay? You always say normal temperature is 37 plus or minus 0.5 degrees and which has got diurnal variations. So if someone asks you what's a normal temperature, you always will say 37 plus or minus 0.5 with diurnal variations. You can't have a temperature for normal. Okay, you can't have 8. It's very important, okay? Because question aata hi hai, we ask this very simple question, what is normal temperature? Okay, so you have to say this term 37 plus or minus 0.5 degrees Celsius with their diurnal variations. This has to be said like this, okay?
So the pathways of fever production, starting from the top left, infectious agents and microbial products as well as cytokines and other inflammatory processes induce macrophages, endothelial cells and reticular endothelial system to produce and secrete pyrogenic cytokines in the circulation. These pyrogenic cytokines induce microbial toxins acting as ligands. These pyrogenic cytokines induce microbial synthesis of prostaglandin in the hypothalamus. In addition to microbial toxins acting as ligands to toll-like receptors in hypothalamus, stimulate the synthesis of PGE2 by hypothalamus. PGE2 raises the thermostatic set point in the hypothalamus to febrile levels. The vasomotor center sends signals for heat conservation and heat production. Heat conservation, vasoconstriction, and heat production by shivering. Corticosteroids induce the peripheral synthesis of pyrogenic cytokines, whereas the antipyretics reduce PGE2 levels in the brain. This is the tabular format. Sorry, this form. So, is general pathogenesis also part, where cytokines released by monocytic cells play a central role in the genesis of fever. Interleukin 1, interleukin 6, and TNF alpha. The cytokine receptor interaction activates phospholipase A2, resulting in the liberation of plasma membrane alketonic acid as substrate for the cyclooxygenase pathway. Some cytokines appears to increase cyclooxygenase expression directly, leading to liberation of prostaglandin E2. This small lipid mediator diffuses across the blood-brain barrier where it acts to decrease the rate of firing preoptic warm sensitive neurons, leading to activation of responses designed to decrease heat loss and increase heat production. In small proportion of hospitalized patients, hyperthermia may result in increased sympathetic activity with increased production. Though there are benefits of fever also, which enhances parameter of immune function, improves antibody production, activates T cells, produce cytokines, enhance neutrophil and macrophage function. Positive correlation between maximum temperature on the day of bacteremia and survival. Temperature more than 38 improved survival in patients with spontaneous bacterial peritonitis also. The downside of the fever is it increases cardiac output, increase oxygen consumption, increase carbon dioxide production, increases basal metabolic rate also, and poorer neurological outcomes in patients with stroke and traumatic brain injury who has temperature. And fever poorly tolerated in patients with reduced cardiorespiratory reserve. Maternal fever causes fetal malformations also.
So after you've understood this much, few things very important over here. Okay, that fever is actually a normal response to a pathogen. It's as simple as that. It's a normal response to a microorganism. Usually, okay, when you look at fever, it may not be because of a microorganism all the time, but it can be because of the liberation of certain elements that may cause a resetting of the thermostat. This is what is occurring. Okay, this is what is occurring. Now, what you must understand is, it is not clearly proven that if you reduce fever, patient's mortality changes. It has not been clearly proven. We know that if the patient has got fever and I would treat it, for example, I gave paracetamol round the clock for every patient, 1 gram 4 times a day, 1 gram 4 times a day, to all my patients I gave, and I stopped the fever completely. The 90-day mortality does not change. It really doesn't change. It doesn't change. Okay. However, there is only one subset in which there is changes in outcomes, and that is in brain related problems. For example, you have a traumatic brain injury. In a patient of traumatic brain injury, there is a lot of sense to actually stop the fever from coming in, not acting when the fever comes in. There are two different things. One is stopping the fever from coming in, second thing is acting when the fever comes in. So in a traumatic brain injury, if you have fever, then the overall outcome of this patient drops significantly. In a traumatic brain injury. You understand? Huh? So in a stroke, in traumatic brain injury, in patients where you have problems in the brain, in that patient you can't come and say, okay, I have fever, I have treated fever. No, it has to be treated even before it comes. Fever has to be round the clock there, it might probably be of significance here. The other thing that we normally say is that when you have fever, the temperature that we're talking, what is the temperature of fever?
36.
Temperature of fever 37.
No.
More than 100. More than 100 for
90.
in ICU patients. More than
You have it
100.
here?
Yes.
Okay, wait. So let's go. So a few things is, so where it is probably going to be of use for us is going to be of use for us. Say for example, you have a patient who's come in with a poor cardiorespiratory reserve. They already have a background problem, and then they have fever. Then there's going to be a problem. You're understanding? Otherwise, fever is beneficial response. Otherwise, fever is a beneficial response. So one more thing that she mentioned over here was it is also related to peripheral neural input from peripheral thermoreceptors. So this, what does this tell you? That tomorrow, if you actually warm up the hands of a patient who's got fever, he will stop shivering. So remember this, okay? So tomorrow, if you have a patient who's having extreme fever, okay, and the patient is not doing well, okay, patient is having fever, and you want to get that fever down because it's very uncomfortable for a patient to have fever, isn't it? He has fever, just warm the peripheries. If you warm the peripheries, because it comes from neural input from peripheral thermoreceptors, peripheral leg and hands, if you warm up, this patient's brain starts feeling that okay, he is actually warm, you don't need to reset the thermostat anymore. So that's a very simple technique to actually get things sorted out. You're understanding? Huh? Very simple technique. So this is very important for you to understand this. Clear? Huh?
There's different measurement of temperature which we can check. Peripheral temperature measurements measured in the outer 1.6 mm of skin or mucous membrane, considered unreliable as influenced by environmental temperatures, mouth breathing, etc. Example, oral temperature, axillary temperature also. Core temperature measurements are not influenced by external factors, more accurately reflects temperature in the internal organs. Example, pulmonary, rectal, esophageal, urinary, tympanic. Most accurate are pulmonary artery thermistor, urinary bladder catheter thermistor, esophageal probe, rectal probe. Other acceptable methods in order of accuracy are oral probe, infrared ear thermometry, Other methods less desired are temporal artery thermometer, axillary thermometer, chemical dot.
So when in any patient that you want to monitor temperature, so the easiest method for you is oral temperature. Okay, remember this. It's oral temperature. Okay, as far as possible, take an oral temperature because it's closer to whatever we had. Bladder thermistor, esophageal temperature, and intravascular temperature that is coming from the tip of a thermistor of a pulmonary artery catheter is the right way to do things. So that is why if you see some patients, I just tell them put the rectal thermometer immediately. The problem with the rectal thermometer is it might be 0.5 degrees higher than your normal core temperature also. The problem with the rectal thermometer, maybe it may be 0.5 degrees even more higher than your core body temperature. So if you have a 102 degree temperature, you can say there is fever, but if there is a 100, you can't say there is fever. Are you understanding? Huh? So that is very important for you to understand. So oral temperature is something that you want to do. Surface temperatures, dot temperatures, chemical dots, infrared, all this is all not supposed to be used in the ICU. Auxiliary temperature, as far as possible, try to avoid. Oral temperature, jitna ho sake utna karna. You don't have any option then you do an auxiliary thermometer. Otherwise, oral temperature is what. That's why we have separate thermometers per patient. You understand? Separate thermometers per patient is for that reason only. Sometimes we do put probes inside, like the pico catheters that we put inside. The pico catheter has got intravascular temperature, so that will give you directly temperature over there. You understand? Huh? Bladder thermistors are the easiest way to actually figure out temperature. Bladder thermistors. However, they are slightly on the expensive side, so we don't buy them. Esophageal probes need a special attachment that requires to be added onto the monitors. So we are not using esophageal probes per se, but we do use rectal thermometers. Importance about rectal thermometers, as I said, 0.5 degrees higher, and it doesn't give you immediate temperature changes. So the temperature of rectal thermometer changes by every 15 to 16 minutes. 15-18 minutes will change hota hai. So if your temperature is changing, then 15-18 minutes it will change. It is not continuous. So don't think I put a rectal thermometer and what I am saying is what is going to continuously vary. It doesn't vary immediately. Okay, it doesn't vary immediately. Clear? You understand? Problem with the rectal thermometer is the spread of Clostridium difficile. Okay, remember this. So when you have rectal thermometers, it can actually cause an epidemic of Clostridium difficile infection. So that's why when you use a rectal thermometer, it has to be gone for autoclave and then brought back. You can't just take it from this patient and put it on to the other patient. It has to go for autoclave because C. diff area. Okay, there's a very high chance of C. diff or some kind of sterilization technique that will get off the spores, which includes washing in water and soap water. Okay, alright, understood? So what is the temperature you use, Niharika, in the ICU? As far as possible, what do you use?
Oral.
Oral. But if you have rectal, if you have rectal, if you have thermistors, that's the best kind of form of therapy to understand temperature, right? Huh? Okay.
So when do we get worried in ICU patients? The definition of fever in ICU is different from the usual definition. Fever in ICU is defined as a single temperature of more than or equal to 101 degrees Fahrenheit or more than equal to 38.3 as per the American College Critical Care Medicine and Infectious Disease Society of America. Also, ACCM and IDCCM recommend that fever in ICU should be investigated only if the temperature is more or equal to 101 degrees. Hyperpyrexia or hypothermia is defined as a temperature of more than 105.8 degrees and is uncommonly encountered in intensive care settings.
So few numbers. So 38.3 degrees for any patient. Okay. However, if you have a patient who has neutropenia.
Yes, sir.
Okay.
Fever in neutropenic ICU patient is defined as a single temperature more than 101 degrees Fahrenheit or 38.3 degrees or a temperature more than 100.4 degrees sustained for more than 1 hour in a patient with an absolute neutrophil count less than 500 cells per minute.
Here again, go behind. Here again, few things over here is this is a very different phenomenon. When you say hyperpyrexia and hyperthermia, they are completely different things. Okay. Hypothermia is less than 35 degrees, hypothermia less than 35 degrees, so number 35 less than 35 is hypothermia. Okay, 38.3 is somewhere where I'm going to investigate my patient. And if it is a patient who has neutropenia, it's going to be 100.4 degrees for 1 hour with an absolute neutrophil count of less than 500. This is clear. But when I say hyperpyrexia, it's a completely different thing. The disease is different. It is not related to something that we are looking at as fever per se. It is something like a heat stroke. Okay, a heat stroke is hyperpyrexia. Malignant hyperthermia as a result of certain drugs is hyperpyrexia. Okay, they are completely different things from infection, completely different things from what we are talking. The difference, can you tell me the difference between both of these?
Set point
Has been changed, number one, then clinically what do you find different? Clinically, these people will not have rigors and shivering. They will not have that only. There is no rigor, there is no shivering. These patients will have rigidity. These patients are going to have rigidity. It's going to be something that you can't treat with a normal paracetamol. It doesn't treat. You will need to give a drug against macular hypothermia for this. Okay, so you can't give paracetamol. You can't do the other way around. That will, or the other fever will not resolve by applying ice and passive physical cooling. It doesn't resolve very quickly. Whereas this will resolve with an ice bath. So patient on the high heat stroke comes to you, put him in an ice bath, it will resolve hyperparexia. You understand? So this is coming after a heat stroke or for a marine hypothermia, whereas this is a completely different thing. So don't confuse these two things. So generally you will not have temperatures of 105.8 degrees. So the moment you start seeing 105.8, you start thinking this is something different. This is not related to the usual ICU fever that we have. 105.8, that's the magic number there. What we know is that once you reach more than 39.5 degree temperature, once you reach 39.5 degree temperature consistently, the overall outcomes are slightly poorer. Okay, if you consistently remain above 39.5, the overall outcomes for any given patient is not very good. Okay, alright?
So even the patient, non-patient will not be useful.
Will not be useful here. So you, in this patient's hyperparexia, if you see a patient, you'll never forget in your life, because those patients don't respond to whatever you do unless you cover them completely with ice. And I cover them completely with ice, nothing happens to them. Okay, they don't respond to paracetamol. You understand?
So, approach to fever. A patient who comes in with febrile illness, cause of fever needs to be ascertained. But patient in the ICU develops fever, what is the cause of the fever? We have to find that out. Then patient with an obvious focus, patient presenting to ICU with fever, patient with an obvious focus on infection, so we need to find out where is the focus. But in acute undifferentiated fever, what is the cause of the fever? Acute undifferentiated fever where there is no specific focus identified. We need to look for we need to find the focus. Acute undifferentiated fever. The first part we saw that there is some focus, the source we know. There is this focus and because the patient is getting fever. But in cases where undifferentiated fever is there, it could be fever with thrombocytopenia, fever with hepatorenal dysfunction, fever with pulmonary renal syndrome, fever with altered sensorium. The fever with thrombocytopenia could be malaria, dengue, leptospirosis, rickettsia infections, viral fevers. With hepatorenal dysfunction, again malaria, leptospirosis, scrub typhus, fulminant hepatic failure. With renal dysfunction, falciparum, typhus, scrub infection, Legionella, pneumococcal infection. Then fever with altered sensorium could be in cases of malaria, the cerebral malaria, encephalitis, meningitis, typhoid fever, septic encephalopathy, brain abscess. Now there are these infectious causes, non-infectious causes as per the systems what we can see. If it's CNS related, we can see meningitis. Infectious causes could be meningitis, encephalitis, brain abscess. Non-infectious could be cerebral infarction, cerebral hemorrhage, subarachnoid hemorrhage. In respiratory system could be sinusitis or ventilator associated pneumonia. Non-infectious could be atelectasis, ARDS, pulmonary embolism, chemical pneumonitis. In abdominal could be nosocomial diarrhea, or in non-infectious could be acalculous cholecystitis, ischemic bowel, gastrointestinal bleeding, acute pancreatitis. In cardiovascular, infective endocarditis, catheter-related bloodstream infection, or non-infectious could be DVT, pericarditis, thrombophlebitis, myocardial infarction. In renal could be infectious causes would be pyelonephritis, and skin, soft tissue and bones causative. Infectious could be septic arthritis, osteomyelitis, cellulitis, abscess, and non-infectious could be decubitized ulcers, gout. In autoimmune, non-infectious part is SLE. We could be in endocrine, adrenal insufficiency, thyroid storm, pheochromocytomia. Miscellaneous in infective could be bacteriemias of multifocal origin, and in non-infective are drug fever, drug alcohol withdrawal, post-operative fever, fat embolism, reaction to contrast agent, transfusion reaction, malignancy, Stevens-Johnson syndrome. Now we go over every part. So ventilator-associated pneumonia. In pneumonia in a patient who has been on ventilator for more than 48 hours, the risk of 3% per day during the first 5 hours of ventilation, 2% per day during day 5 to 10 of ventilation, and 1% per day after that. Attribute mortality has been estimated to be between 30 to 50%. Now, definition of VAP is new onset of progressively increasing infiltrates in chest X-ray, fever, leukocytosis, purulence of tracheobronchial secretions, at least 2 out of 3 has to be there. This is the clinical pulmonary infection score for suggestive of VAP. So then other part is diarrhea also in patients. So Clostridium difficile could be most common in uncommon nosocomial infection. Pseudomonas and Clostridium septicum in neutropenic patients which can be seen cause. This is about Clostridium difficile in detail. Clostridium difficile colitis. The symptoms can begin shortly during after antibiotic therapy, but are occasionally delayed for several weeks. In this, neutrophilia and increased fecal leukocytosis can be seen. This is about the diarrheal infections. UTI infections also there, where we have to further this is the part where we are investigating to see about which particular different systems are there and how we can go ahead and approach for the cause. So in UTI is one of them. Bacteriuria, candidiuria definition was called quantitative culture of more than 1000 CFU per ml has been reported in 30% of catheterized hospital patients. In these patients, dysuria, urgency, pelvic, flank pain, fever, chills can correlate with significant bacteria in non-catheterized patients are rarely. Then catheter-related bloodstream infection are fever, sepsis, inflammation with or without purulent discharges at exit site, difficulty in aspirating or flushing from CVC. Only 25 to 45% of cases in sepsis in patients with CVC have CRBSI. So we need to do routine cultures of the tip in absence of sepsis is not recommended. If fever is there, if counts are also increasing, then we can go ahead and do that. Then in CNS infection, as we discussed already, in altered sensitive focal deficit neurosurgery cases, how we go ahead. If it is suspected meningitis, and we can go around and do CSF analysis, lumbar puncture, and cultures we can send cultures of the ventriculostomy drain also, and in case removal of shunt. And suspected supratentorial pathology, we can go ahead and do a CT head, find out the abscess and do abscess aspiration of abscess. These are all examples of the infection causing fever, fungal sepsis. Now non-infectious fever, DVT, pulmonary embolism can be associated with fever up to 50% also, but fever does not warrant routine initial investigation for DVT because of poor predictive power of the fever in cases of DVT. Now neuroleptic malignant syndrome, it is idiosyncratic reaction to neuroleptic drugs, that is initiation or change of doses, and it can manifest altered mentation, hyperthermia, muscle rigidity, rhabdomyolysis, autonomic dysfunction. Also due to antipsychotic medication, antiemetics, withdrawal of levodopa. In the ICU, haloperidol is most commonly offending drug, causing fever over here because of the drug. So in such case, we have to manage withdrawal of the offending drug in ICU basically. So febrile transfusion reactions, now they can complicate about 0.5% of blood transfusion, more commonly following platelet transfusion. Antibodies against membrane antigens or transfused leukocytes and platelets are responsible and usually begin within 30 minutes to 2 hours after blood product is transfused. Fever generally lasts from 2 to 24 hours and may be preceded by chills. Acute leukocytosis lasting up to 12 hours occurs commonly, febrile transfusion reaction. These are non-infectious causes, as we have discussed already. So what investigation should we send in such cases? Infectious and non-infectious both. So blood counts, procalcitonin, imaging we should do to find out this focus, chest x-rays or scans or CT brain or abdomen. Cultures appropriately has to be sent whether from the ET or bronchoalveolar lavage, urine, blood cultures, peripheral lines and central lines also, cultures from pus or bone or stool from Clostridium. Now workup for fever, how we go about in this. Now if temperature is more than 38.3 degrees Celsius or more than 101, then what we review possible causes and draw possible causes, and we draw two sets of sterile blood cultures. Mostly if we have a central line and then we take 2 bottles from central line, 2 from the peripheral line. So if there is no obvious cause and clinically stable, then we monitor closely. If fever recurs, then possibly chest X-ray we repeat, and cultures could give us the possible source also. In possible infective sources, in intubated patient, intravenous arterial catheter, Foley's catheter, nasogastric tube, surgical vein, diarrhea, this could be the place where we should draw cultures also. In immunocompromised patient or clinically unstable, we again have to take cultures. After sending cultures, because the cultures would take some time to get the report, broad empiric antibiotics coverage based on likely pathogens, which on clinical condition we have to evaluate, we have to start. If there is improvement, monitor closely. If there is no improvement after 48 hours or there is worsening, then in cases of any lines, external source, consider changing of lines and catheters, and consider antifungal treatment, CT imaging, Dopplers to find if non-infectious causes there. Same for that. Treatment of fever and hyperthermia, antibiotics, external cooling, cooling by blankets, sponging, fans, ice baths, internal cooling by gastric or peritoneal lavage, IV fluid replacement, cold saline infusion also we can do, hemodialysis. Hemodialysis as sir just now in CRRT lecture we told that we can, if you want to completely get down to fever, we can go ahead and do hemodialysis. Endovascular cooling, catheter, sedation and paralysis. Drug-induced hyperthermia, remove inducing agent as we saw in the syndrome. Pharmacologic therapy, dantrolene, bromocriptine, physostigmine, procainamide.
Dantrolene is not available.
Please.
Thank you.
Subject. Okay, how do you deal with this? How do you deal with this is very important. First of all, you should know what is the trigger. What is the trigger for you to start an investigation? Okay, what is the trigger for you to? So three triggers. क्या हो गया? नहीं. So there are few things that you must remember. Okay, the first trigger is when do you trigger an investigation? Okay, that is the first trigger. So when do you trigger? So trigger for investigation. So what do you think is a trigger for an investigation? So let me give you an example. You have a patient who's in the ICU. Trigger for investigation. Okay, which is the trigger for investigation? So you have a patient in the hospital, basically presented to the situation with diabetic ketoacidosis, for example, and was put on a ventilator. Now you have put on the ventilator because patient had acidosis, and that's why patient was on ventilator. So ventilator पे ले लिया तुमने, you started resuscitating your patient. Now it's day 3, day 4. Okay, now the patient develops a fever, and he gets a fever. When will you think about investigating? When will you think? What is the first trigger? When will you start thinking? Which patients you will investigate? Which you will not investigate?
If the BP is continuously on the lower side and it's not coming up even with adequate fluid resuscitation.
So any patient that gets unstable, with fever, for example, starts developing hypotension or starts developing an extremely fast pulse rate which is not responding. Pulse rate is going to go fast, but it becomes unstable. Patient's urine output is dropping in the last couple of hours, though you have given fluids. Unstable. Patient is getting unstable. So in that patient, you would want to investigate. Number one, you want to start investigating. Then
to identify source of infection.
No. Which patient you will want to identify? Which patient you will want to do this? एक तो ये हो गया unstable patient. So I have a patient. Say this diabetic ketoacidosis patient was okay, and developed a fever spike. Okay, but was just had one fever spike. Would you go and do an investigation for this? No, you won't. You will not do it. Okay, because you must know that 50% of ICU patients would have infectious etiology. How many? 50%. 50% would have infectious etiology. The other 50% don't have infectious etiology. The other 50% don't have an infectious etiology. So there is no point of going and figuring out an infection protocol for 50% of your patients. Are you understanding? So a single fever spike should not make you go ahead and do investigations. No. First of all, your fever spike in those patients who have septic shock, who have neutropenic sepsis. they are the ones you will want to investigate. Surely. So if you have a patient who's having neutropenic sepsis, when I say absolute neutrophil count less than 500 or less than 1000 hour WBC count, and this patient has got a fever of 100.4 degrees for at least 1 hour, that patient I have to investigate. That patient I have to investigate. So neutropenic fever and septic shock. There are two patients where I cannot stop, but I have to investigate. And the third patient is the one that is unstable. So these are the three category of patients that I will want to investigate. Clear? Clear on this? Because I am not expecting to have problem immediately. There are other reasons why a patient can have fever. For example, you have a patient who comes in post-operatively. When we come to non-infectious causes, one of the prime causes is post-operative fever. Post-operative fever. So that would be a post-operative fever. It may not be an infectious cause. You understand? Which of these patients you will treat? Or when I say treat, what do I mean? Giving acetaminophen. When I treat, I mean acetaminophen, not antibiotic. Antibiotic is not the treatment for a fever. Antibiotic is not a treatment for a fever. Okay. And which of the patients I will give an acetaminophen or paracetamol? I'll give those patients who are having neurological problem. Who are having what? Neurological problem. So if he has neurological problem, for example, he's come in with a meningitis, or he's come in with a traumatic brain injury, or he's come in post-surgery. Those are the patients in which I will probably want to actually give acetaminophen. So I will not give it to every patient that is there in the ICU, because more often than not, fever will go up, fever will come down, because that is what we understood in pathogenesis. What did we understand? That fever will go up because of the stimulation of cytokines, phospholipase A2, and then the reset of the osmostat, and then fever will come down. That is what we know, isn't it? I will, yes, take care of the water loss that is happening, I will take care of the dehydration that is happening, but I will not go and act against that fever as of now, not required. Not required. Okay, that is important for you to understand. It will come down. Okay, but doesn't underlying है तो बात अलग होता है. Okay. So that is where I'm going to trigger an investigation. So I trigger an investigation if the temperature is more than 38.3 degrees consecutively with acute circulatory failure, and I think that there is a possible source of an infectious cause of fever. Okay. Now when I say trigger an investigation, I have to find out whether it is non-infectious or whether it is infectious. This is how I will think. This is how I will think. I will immediately think whether there is non-infectious or whether there is an infectious cause of fever. 50% of the time it's going to be an infectious cause, and if the patient is on the ventilator, the first thing I have to think always is ventilator associated pneumonia. The first thing I have to think is ventilator associated pneumonia if the patient is on the ventilator. For example, our patient. So the first thing I will think is ventilator associated pneumonia in our patient, given the condition that the patient has been on the ventilator for 4 days. Okay, this is the first thing I think. And why would I think about this? Because in intensive care, we will first tackle the things that give the highest mortality. In intensive care, we first think the things that have the highest mortality and try to rule them out. Okay, for example, when you do a ultrasound for a patient who is hypotensive, I will first find out cardiac tamponade. If I have to do it, right? I will not go and do groin and ultrasound and pleural effusion ultrasound. I'm not going to do that. I'm going to start by doing cardiac tamponade. Similarly, in this case, if I'm thinking of an infectious pathology, my first thinking would be, is there a ventilator associated pneumonia in the first place? If it's an infectious pathology. Okay, so I will not go and send tracheal cultures for this. What will I do here? I will first see clinically whether this patient has got VAP features or not. Is there a new onset or a persistent patch that has come in? Has the secretion volume, purulence or quantity changed? Has the requirement of FiO2 and PEEP gone up on my ventilator? Is there an ultrasound that shows that there is a new forming air bronchogram that I am seeing over there? Am I actually auscultating very harsh crepitations which were not there in the past? In that kind of patient, and there is a presence of a patch, I may want to do a tracheal culture. Why? Because as I told you, every patient that gets a plastic will have some amount of organism on that plastic. They will have some organism on that plastic, and that is called as tracheitis, inflammation, it is colonization, it is not something that is causing an infection. So for ventilator associated pneumonia, I should have the presence of a clinical and an imaging pathology that actually tells me that there is something that is developing over there. I'm not going to go and do a tracheal culture on this patient. You're understanding? Samajh mein aa raha hai? So you might say, I'll give some mini bar, I'll put some water and take out. No, I don't. That is not the cause. You understand? For that I should see it. It is only in cases of febrile neutropenia where I may not get a patch. So in cases of febrile neutropenia, what unfortunately occurs is the body doesn't respond like the way any other body responds. Your body gets a pneumonia, develop a patch. A febrile neutropenia may not develop it as quickly as we thought. So what will happen in febrile neutropenia? You need to do an imaging modality that is higher than an X-ray. It will probably require a CT scan. You understand? So the difference there on the investigations for an infectious cause when you have febrile neutropenia is that I will not wait for anything to happen. Here I have not even thought about a blood culture. You see, I have not thought about. But in febrile neutropenia, I will start sending blood cultures. You understand? So my trigger for an investigation in an infectious pathology in neutropenia is different when it comes to sending blood investigation. So in neutropenia, if I have a patient and he has got fever, I will send blood cultures. But if I have a patient who has fever in the ICU, I will not send blood cultures. It doesn't make sense. It doesn't really make sense. Okay? It doesn't make sense at all. Right? So ventilators will pneumonia. Then the second thing what I do next over here is I will look for other sources of infection which include central lines. I have not even come to urinary tract. You understand? You see very clearly, I am not even talking about urinary tract. Okay, I am not even talking about urinary tract. And the next thing I am looking for is for central line. And that also I am not going to send a blood culture again. What am I going to do? I am going to look at the line. I am going to look at the line. I am going to look whether there is an exit site infection. I am going to look how old the line has been. What is my rate of infection in my ICU? Do I need to really send the central line culture? That is what I am going to think. I am going to think like that. Because I am going to look whether there are other alternative sources of an infection. You understand? So, two things I have looked for. Ventilator associated pneumonia and central line. These are two things that I want to look at. Whenever I have a patient who has a central line and who has, in which I am thinking of an infective pathology. Then the next are very localized. The next are very localized. For example, you will have diarrhea. I am not looking at malaria, leptospirosis and all this over here. I have diarrhea. What does diarrhea indicate in a patient who has been in the hospital for a couple of days? Sorry? No. What when we are looking at pyrexia, no? We look at pyrexia. Clostridium. So I will be looking at clostridium here. So when I go ahead, I will be looking at Clostridium difficile infection. Okay, when the patient has got diarrhea, it's a localized feature of diarrhea that I'm getting. Okay, then I'm going to look at an infectious pathology, and in my infectious pathology, the one that I will look for is for Clostridium difficile. Clear? Clostridium difficile. This is the infectious pathology I'm going to look for if I'm having diarrhea. Urinary tract, I have not yet come. I'm not going to go to that also. Refrain from sending pan cultures. For example, okay, there is a fever, send into secretion, send a urinary tract culture. No, send blood culture. No. Never do that. Never and never do that. Do it in this order only. Infectious disease agar aa gaya, the first thing I'm going to think, if I'm thinking infection, is going to be ventilator associated pneumonia. Let me look at signs and symptoms whether it is there, and that is where your clinical diagnosis comes in. That is where you are as a clinician working. You are working as a clinician to figure out, oh, is there a chance that this patient has got ventilator associated pneumonia? That's what I'm going to first answer. Okay. The second thing would be central line. I'm going to look at it as a clinician. Okay, what is there? Is there an exit site infection? Do I think that there is? What is my approximate rate? Do you think that I have put this under emergency care? Have I put industrial precautions? Is it the femoral line? Is he obese? These are the things that will come into my mind when I'm looking at central line infections. Then I'll come to Clostridium difficile, where I'm going to see there is diarrhea. Okay, there is possibility of this patient having a Clostridium difficile infection. The rest of the things that we have, like meningitis, will come only in a significant case. For example, you have a patient who has undergone a neurosurgery and has got an external ventricular drain in place. Then I'll think of ventriculitis. Far-fetched. Very, very far-fetched. Okay, that a patient who is having a ventricular drain develops a ventriculitis. Far-fetched. It's not something that's very regular. Okay, but that is how I'll be thinking. I'll not be going and thinking that this patient has got meningitis. It's impossible. Hematogenous spread of infection is not something that occurs like this. Hematogenous spread of infection. Usually, hematogenous spread is spreading to different organs would generally occur when there is gross infective endocarditis. So, if you have a patient who's got infective endocarditis, then I would probably look at infectious causes going here and there. Infective endocarditis per se will have patients who have fever, not looking good, prostrated, not okay. They will send off in small amount of infectious organisms to the spleen, to the brain, to different parts of the body, to the spine and things like that. You understand? But otherwise, other patients will not need to be looked at this way. Clear? So now that you've gone through the infectious cause, this much is this is it. You will not probably want to do anything further than this. Are you understanding? I will come to the non-infectious cause, which is more important. Okay, over here what comes is very, very more important is non-infectious cause. In this, outside causes are of drains getting infected, of post-operative drains getting infected. Okay, outside causes, very outside. That means it's just poor management. Outside of this, all this, if you look at it, they are just poor management. You're not even coming to that. Because urinary tract infection, you cannot prove in these patients. As I told you last time, it was very difficult to prove patients with urinary tract infection unless you have real flank tenderness and pyelonephritis and this is a fever that came in after 4 days. Less likely that is going to be, if at all it may be, so diagnose COT is easy to diagnose in the ward, but very difficult to diagnose in the ICU. You understand? So I will not even send, because what you will do for COT, you will send urinary culture. No, I won't do that. You understand? You will get into post, because here this patient is on a ventilator. To diagnose it, you do the ultrasound. It's impossible to actually figure out. You understand? COT is something that you must be very careful before diagnosing. Right? Now comes the non-infectious cause, which is a bigger window of getting non-infectious causes. For example, if you have a patient just on the ventilator, a simple transfusion reaction can also cause the patient to have fever. A simple transfusion reaction. So blood transfusion done maybe a day ago can actually cause even fever a day later. Okay, that is as simple as that, blood transfusion reaction. Then what can be the cause? Another possibility is of something called as acalculous cholecystitis. Many of these patients are not getting fed well. Since they are not getting fed well, the gallbladder distends, and the distension of the gallbladder and its wall causes these patients to have fever, which is an alarming situation. Okay, acalculous cholecystitis is not something that is simple. Patient can go into very difficult and it can be fatal and lethal. So acalculous cholecystitis. Then, tell me some more. DVT, yes. So DVT is another cause. So DVT is something that you look at. I look at deep vein thrombosis where these patients have been immobilized for a while, and you probably get DVT. Very simple to diagnose femorules. Then, more importantly, easier. Sorry. Pancreatitis. So abdominal pain over here will actually signify to you as pancreatitis, which will require higher investigations when you look at pancreatitis. Then, more simpler things. Atelectasis. So post-operative atelectasis is a very common cause. They are normally for the first 1 to 3 days. If you have fever in a patient who is post-surgery, more often than not, it is post-operative atelectasis. Atelectasis will actually cause the patient to have fever. Atelectasis. So in the first 3 days, if you get fever, most often it is going to be atelectasis. It is going to be atelectasis. You understand? Clear on this? Then after atelectasis, DVT, okay, then other rarer causes. Which are the other rarer causes that you know? So these are the common causes that we talked about, atelectasis. Of course, we forgot one important infectious cause here, which is infectious decubitus ulcer. Cellulitis basically. Decubitus ulcer. Decubitus ulcer causing cellulitis. That is one part which we forgot in the infectious cause. That comes in a patient, specifically a patient who is being mechanically ventilated, decubitus ulcer that is infected, that will come in over there. But what about the non-infectious causes? Now comes the rarer causes. Which are the rarer causes that you know? Which causes non-infectious? Pulmonary embolism. So that is a very rare cause which can occur in patients who are being ventilated, who's been in the hospital for a while. Pulmonary embolism is one of the rare causes for this. Another thing, myocardial ischemia, myocarditis and myocardial ischemia. These two can cause patient to get fever. Another common cause, hemodialysis. Hemodialysis itself will cause fever. Dialysis itself will cause fever. Okay, it's a procedure-related cause, right? Any procedure, like for example, a blood transfusion or a hemodialysis, both of them can lead to fever. Okay, so it can be just fever. Then, if you rule out all of these things, you will definitely talk about neurogenic fever, right? Neurogenic fever. Now, what is this classical neurogenic fever? This neurogenic fever will be sympathetic overactivity. You will have the pulse rate to be fast, you will have the BP to be high, and these patients will have unrelenting fever. Fever not coming down at all. You have ruled out all infectious causes, but the fever is just not coming down. That is called as neurogenic fever. Okay, these patients classically will have sympathetic overactivity. Their pulse rate will be fast, their blood pressure will be high. They may not be even diaphoretic for that matter. They may not be very diaphoretic. And then you may require drugs like bromocriptine to get them down. Right? Then after that, the last and most important and one of the very common causes that you may possibly get is called as drug fever. Now, what is drug fever? Drug fever is, what is drug fever? So drug fever can be caused by anything. It can be caused by an antibiotic. Obviously, the commonest is the beta-lactam antibiotics that we use, like cephalosporin Laelia, meropenem Laelia. Any of these antibiotics can cause fever itself, drug fever. Okay, drug fever, when does it occur? How do you understand drug fever? So drug fever can occur because of antibiotics, can because of antineoplastics. It can occur because of any of the drugs that you're using, including an antac and subralbate. Okay, so how do you recognize that it is a drug fever? First of all, you will definitely look at all other causes and rule out everything else. You rule out that it is not BAF, it's not C. diff, it's not this, it's not that. You rule out everything. And at the end of the day, you have only one thing that is there, the drugs are left. So how do you know? So classically, drug-induced fever comes somewhere around 8 to 10 days. It doesn't come immediately. Okay, the time duration is, it takes 8 to 10 days before you get a drug fever. Now drugs like even enalapril and captopril, which has been started say 40 days ago, can actually cause a drug fever at 40th day. So the median time for drugs like cardiac drugs are somewhere around 30 to 40 days also. Okay, median time. So that's why you start thinking of a drug fever once you're 10 days after a drug. Once you're 10 days after a drug. So 10 days after a drug, you start your drug fever. 18% of these cases will have eosinophilia, and 18% of these will respond to antibiotics immediately, and 18% will actually relieve. And what is the definitive point? Cut off all those drugs. Take off the drugs off, and the fever will actually come down. Take off all those drugs, and the fever will actually come down. Okay. That's why in some of these patients you might see I might come and just cut off all the drugs. I do that, right? I come and cut off all the drugs. The reason I do that is this patient has got a small fever spike. I don't think this is septic fever. For example, take Patricia, isn't it? What did I do? I just came and cut off everything. I just mopped off everything because the fever was what? 99.8. You kept telling me 99.8. You was thinking 100. I will act only when it's more than 101. You know, I'm not going to act it at 99.8. You kept telling me that. So what did I do? I just cut off everything. I cut off everything. I did an ultrasound. I found collapse. Then I know, okay, this is where the fever is coming from. So let me just ventilate her properly. Let me try to diurese her as much as possible. Just now, diurese hone do, and cut off all the rest of the drugs. I looked at DVT, there's no DVT. You understand? So I will not act on that particular patient.
Does it mean that drug-induced fever, antibiotic-induced fever can also occur within 8 to 10 days also?
Yes, it will occur only after 8 to 10 days. It doesn't occur early. So what happens is you start an antibiotic, say penicillin you start, 8 to 10 days later you will find the drug fever to come in. These drug fevers are not very high fevers first of all. They are fevers that are on the lower side. They are not very high fevers. So 105 plus are malignant hypothermia, 102 to 103 are the ones in which I am thinking of an infective cause of origin, and anything below that is generally considered to be somewhere that is non-infectious and including drug fever. So that is a way you clinically can figure out. Okay, it's not certain that way, but that is a kind of a guide. कि 105 के ऊपर अगर गया, then it is probably a kind of a malignant hypothermia. If it's somewhere between 102 and 103, 104, it is something that is related to infectious causes. And if it is less than 102, 101, you should look at and rule out non-infectious causes for fever. Okay, so drug fever, some of them have eosinophilia, some of them have leukocytosis. You don't need to have drug fever to have leukocytosis. 18% of them will have leukocytosis. Okay, issue is that it's not that it is not this way that drug fever will not have leukocytosis. It can still have leukocytosis. Drug fever. So don't look at WBC count. So if you look at all these things, WBC count is not figured over here. If you look at all these things, where is WBC count? It's not figured over here. Because WBC count sensitivity to diagnose a fever is extremely low in intensive care unit. You understand? In intensive care unit, the sensitivity to actually diagnose infectious cause with WBC count is extremely low. You understand? So today, if your WBC count goes up, it doesn't mean you have an infection. It doesn't mean you have an infection. In the context, so WBC count is always thought in the context. It's never thought on its own. You understand? Clear on this? So at the end of the day, it is only in these cases where I would think of an antibiotic, and that also the antibiotic will be dependent on the source of the infection that I'm looking at, right? Whereas on this side, it is completely different management. The management completely differs on this side. Management completely differs where I probably want to get on the atelectasis, I want to treat the DVT, I want to ensure that I'm not giving any more blood anymore, I'm removing the allergic reaction if it is there, cutting off drugs. So these are the things we are going to look at when you're looking at non-infectious causes. Clear? So here when we discuss VAP, the VAP diagnosis will be based on that. The central line diagnosis will be based on that. C. diff will be based on when we discuss C. diff. You understand? Clear? Any queries on pyrexia?
Sir, what about that thing with kind of malaria, dengue?
It doesn't come here only. We are not considering malaria, dengue, and typhoid to be in the hospital. It is not something you should get. Malaria, dengue, and typhoid. Where you will get? You will get in the community. It is not something you will get over here. You will not get tuberculosis, meningitis over here. You understand? We are dealing with a patient who gets pyrexia inside the ICU. So classically, they are not going to have malaria, dengue, and typhoid. So you're not going to send RMAT, urea, dengue, and all these things for these patients. We don't do that. So here it is very clear. We are not, thinking too hard. But we are clinically using our knowledge to as much of a skill as we can. Our knowledge, our clinical know-how is where you want to look at here. Our entire thing is that clinical know-how. You understand? You can't just send multiple investigations. It's wrong to do that. It's very, very wrong to do that. Okay? Clear? And whenever you have an infection, whenever you have something like this, one thing that can help you to understand whether this patient is going haywire, there are a few things. One is the neutrophil lymphocyte ratio rather than the WBC count. Look at the neutrophil lymphocyte ratio. So if the neutrophil lymphocyte ratio shows that it is somewhere above, say, 8 or 9, okay, neutrophil lymphocyte ratio means this patient is not doing well. That is what I know. If I do a lactate, I know this patient is not doing well. It doesn't tell me there is an infection. It doesn't tell me there is an infection. It just tells me that the patient is not doing well. Procalcitonin, it doesn't tell me that's an infection. We know that procalcitonin elevates when there is bacterial infection. We know that. However, it is not sensitive enough for you to diagnose it to be an infective cause of problems. Because procalcitonin can go up even with renal failure, it can go up with multi-system organ failure, it can go up with a lot of conditions. Even some inflammation can cause, even some non-specific problems can cause the procalcitonin to go up. However, procalcitonin is a great drug if you want to de-escalate an antibiotic. Great molecule if you want to de-escalate. So among the biomarkers, CRP, procalcitonin, these are all things that you are going to add to your clinical acumen. It's not something that you use first and then you use your clinical acumen. It is additional to your clinical acumen if you want to use procalcitonin or CRP or lactate for that matter. You can't use it in space. For example, you have a fever, I'm going to send a procal. It doesn't make sense. No, it doesn't make sense. I have a fever, I have a patient who's having Clostridium difficile infection, I have a patient who's having ventilator associated pneumonia. I know that this is going to be bad. Why do I send a procalcitonin? There's no requirement to it. You understand? You understand what I'm saying? There's no reason to send a procalcitonin for these patients. You understand? I want to do a CRP, maybe I want to see the inflammation, maybe think that's fine. You want to do an inflammation, okay, my inflammation is coming down. That's all that you can understand. Because you can't understand anything as a marker of sepsis. There's nothing like a marker of sepsis. Where you can just see, okay, take this and this is sepsis, this is not sepsis. No, it's a complete clinical call. Any further questions?
So if the patient is suppose 99.8, 100 temperature.
I'm not worried.
No, nothing to do, or we hydrate or something.
If you feel that the patient requires hydration, that we can do. But hydration also, more often than not, we don't require. Most often our patients now are not fluid responsive in the first place. So hydration also, when you say hydration is 100 ml per rise of fever, 100 ml per 1 hour. So, but these normally they're not a 1 hour fever and all. These fevers will come and that go. So for a 10-minute fever, you don't need to give fluid. Are you understanding? If you have say 2 hours of fever, 3 hours of fever, there I want to take care. Okay, but if you have 10 minutes of fever, which is just going to come and just, classically it happens like that, no? You have fever, you give paracetamol, fever gaya. I saw that, no? You see that, right? That's it. So for that, what fluid, what you do? Nothing. Are you understanding? So I will not act. So that is why I started by saying, what is my trigger? What is my trigger for investigation? What is my trigger for treatment? The trigger remains as 38.3 degrees temperature. That has to be a trigger, 101 degree Fahrenheit. So don't report 99, that's why I don't even look whether 99.4 I just leave it, okay, that's fine. You would have noticed it. It's not something that I'm worried about, because more often than not, I would be right in investigating if I am really thinking of an infectious cause. Otherwise, I will not be sending cultures. I will not be sending cultures or here or there. That is a culture I will think hard before doing a culture. I will look here, look there. I will think, okay, this is the problem. Let me do this. That is what I will do.
So, sir, this 101 is basically for the patient who is in sepsis.
For any patient. So, if you have a patient in the ICU and develops 101 degree fever, I should start thinking I need to investigate this.
Wow.
I need to look. There is a problem. But if the patient has got 99 degree, Okay, 99 degree, I'll say it's only 99. That's all. See, tomorrow when you play football and you hurt your leg and you go home, you take an antibiotic or what? But you get fever, no? Sometimes. What is that? It's just an inflammation, right? You don't need an antibiotic for that. Right? You tomorrow exert yourself, you go home, you get a fever, right? When you get a fever, that is exertional, nothing more than that. You don't go and give an antibiotic for that. These patients are in severe stress. You know, that severe stress is causing their fever to come in. But that fever is 99 degree, 99, 100 degree, it's not 101. So my reason to investigate would be, as I told you, if the temperature is more than 101 and there is a presence of something that I am thinking as a source of my infection, or there is a presence of acute circulatory failure in some manner, or there is some kind of patient who is on neutropenic sepsis, where patient can be stable still. In neutropenic sepsis, I will not think. Neutropenic sepsis patient WBC counts are 500. No. I will do everything. There I will not think what is the source. I will do an X-ray, I will do a CT scan, I will send blood cultures, I will do everything possible, because these patients will not really actually reveal anything per se. Here people are revealing, no? In that people are not going to reveal. The patient is not going to tell that I am having this problem because usko aata hi nahi kuch bhi usko. So there is a role for a complete change of antibiotics empirically, which are not doing any of these patients. It is only in the neutropenic sepsis patient that where I am thinking that the septic shock patient where I think that let me change my antibiotics. Are you understanding? That's where it is a trigger for my for infectious problem. Of course, all this this is like a guide. What I told you is like a guide. Okay, don't follow it exactly to the toe, but you should now develop a clinical skill to understand which patient I should do things, and that will come only by you first understanding this backbone. If you understand this backbone, then you'll understand. Okay. Now I need to, for these patients I need to send my. It's very interesting to actually figure out, and then when you feel good, the day you figure out, this is what had happened, and now this is this. So I know this is what the problem is. Okay. Any other question?